Good evening, everyone. So, this week our lecture will discuss the rare variants of leprosy or the unusual presentations of leprosy. Now, leprosy is not limited to the Ridley-Joplin classification that we usually see. You won't get all patients in BT, BL, or LL form. You will get either a part of the spectrum going from BT to BL or to subpolar LL, or you will get unusual forms of leprosy, like you would get histoid leprosy or Lucio phenomena or Lazarine leprosy. So we'll discuss all of these unusual forms this week. Okay, we have discussed the unusual form of histoid leprosy last week, and I had made a special video, a separate video for Sapphire members in which we discuss the Lucio leprosy or the Lucio phenomena in detail. Okay, in this video, we'll cover all of the rare variants or the rare morphologies or the rare presentations of leprosy or the unusual which are not so common, so that you can always keep the diagnosis of leprosy at the back of your mind. Okay, so you will remember to keep leprosy in differentials when you kind of suspect it, so that your suspicion of leprosy or the threshold of suspecting leprosy should be a bit lower, and you should always be cautious in keeping in mind that leprosy can always be there and can present as anything and everything under the sun. Clear? So with this video, we'll discuss all the rare variants of leprosy. And without much further ado, let's discuss the variants. Let's move forward. Now, we'll discuss the unusual presentations of leprosy. And these are those presentations which do not fit into the standard classification of disease. We know that we use Ridley-Joplin classification, which is a histopathological, clinical, and immunological classification. However, nowadays we do not use the immunological part. You require lepromatous for that, but we use clinical histopathological classification known as Ridley-Joplin. Now, these unusual variants are those variants or those morphologies which which are not easily classifiable as per Ridley-Joplin. Okay. While discussing the histoid leprosy, we discussed different forms of leprosy. For example, we discussed that how histoid leprosy is known as the eighth form of leprosy. We see the five forms in Ridley-Joplin: TT, BT, BB, BL, and LL. The sixth form is the pure neuritic. Okay, and the seventh form is indeterminate, and the eighth form could be considered as histoid Hansen's, or vice versa. Others regarded as okay. So, apart from these eight morphologies, you can have different presentations of leprosy. In fact, we have discussed one unusual presentation, which is histoid leprosy last week, and we have discussed Lucio phenomena for Sapphire members a week before that. The problem arises that because of these different and variable presentations, a diagnosis of leprosy could have some difficulty. You could have some kind of hesitation in making a diagnosis of leprosy. In fact, multiple differentials are considered before even thinking of leprosy. In this case reports, while we're discussing the individual case reports, you will find that most of the time the differential leprosy was not kept before doing a biopsy, but on biopsy you see swarming foamy histiocytes and AFB positivity on white Falco stain or white Wade fight stain. On the special stains, you see mycobacterium staining as red bacilli. And when you do PCR analysis, the diagnosis of leprosy is confirmed. So, because of multiple differentials, there's delay in proper diagnosis. You're not able to make a proper diagnosis earlier and start on MDT. So we need to know that leprosy can have variable presentation. Always remember that leprosy can affect any organ of the body. There are exceptions as of now, and those exceptions are asked in the exams. And we have covered those exceptions while discussing systemic manifestations of leprosy. So you can go back and look at that lecture, and we have discussed some of the organs which are not so commonly affected by leprosy. But remember, leprosy is a disorder of skin and nerves, but can involve any other organ of the body. So we need to know their manifestation and presentations. Clear? Let's move forward. So let's start with the first unusual presentation, which is Lucio leprosy. I have discussed Lucio leprosy separately for Sapphire members. So if you are a Sapphire member of the channel, you will have a separate video under the playlist of leprosy in which we are discussing Lucio phenomena in detail. You do get a short note on Lucio phenomena, so it's better that you can read about it. Okay. Now, Lucio leprosy is a pure primitive diffuse form. The focus is on diffuse. So in Lucio leprosy, you have a diffuse infiltration of the skin. Okay, you don't. It may seem like lepromatous leprosy, but in lepromatous leprosy, you have delineated plaques of infiltration at least. Okay, while in Lucio leprosy, you have a diffusely involvement of the body in the form of infiltration. It was described in Mexico. In fact, most of the time, about one-fourth of the cases are in Mexico only. Other countries like Costa Rica and South American countries, and in fact, rising in incidence has been found in the Southeast Asian countries also. The organism involved has been touted to be Mycobacterium lepromatosis, discovered in 2008. We have discussed that in detail in that separate lecture. And this is the second causative agent of leprosy. Some authors think that it's a mutant form and of M. leprae, but by 16S ribosomal RNA analysis, it has been found to be a separate species from M. leprae. Lucio leprosy is also characterized by Lucio phenomena. In Lucio phenomena, you see a lepra reaction that has excessive necrotic presentation. In fact, most of the times, it is confused with necrotic ENL. We have discussed the difference between ENL and necrotic ENL in that separate lecture. In fact, Lucio phenomena is considered as a type 3 lepra reaction. So we have type 1, the neuritis form, type 2, ENL, and type 3 lepra reaction. In Lucio phenomena, you see excessive necrotic vascular infarction and ulcers. Clear? Let's move forward. Lucio leprosy is part of MB spectrum towards the lepromatous pole. That means the infiltration by Mycobacterium leprae is extensive and covers a larger area. Treatment includes continuation of MDT and steroids, but it doesn't respond much to thalidomide. In fact, necrotic ENL responds very well to thalidomide. ANL responds very well to thalidomide, but Lucio leprosy has not that good a response to thalidomide. The term lepra manchada is an older form of Lucio phenomena or an older name for Lucio phenomena. So this might be asked in some quiz that lepra manchada is a form of Lucio phenomena or Lucio leprosy. Clear, but it's an older form, older name. We don't use that name anymore. So for Sapphire members, we have a separate video discussing Lucio leprosy. If you're a member, you can get access to this video and you can discuss and see what is Lucio leprosy in detail. The second form is Lepra Bonita. So Bonita in Spanish means beautiful. Okay. So what happens in Lepra Bonita is that there is diffuse infiltration of skin. Clear? It is same as Lucio leprosy. In fact, many authors regard Lepra Bonita as a part of Lucio leprosy. So because of diffuse uniform infiltration of the skin, okay, diffuse uniform infiltration of the skin appears stretched, smooth, shiny and waxy appearance. Okay, it is smooth, stretched, shiny and waxy. So the skin has a certain shine to it in Lepra Bonita, and this shininess, this stretched nature, there is not much wrinkling. Okay, because of the whole infiltration of the skin, you see Lepra Bonita or beautiful leprosy. The patient appears as if the skin is very beautiful. So that is why Lepra Bonita. You have sheet of barely perceptible infiltrated skin. You don't see the leonine faces that we see in lepromatous leprosy. We see a diffuse infiltration with shininess and waxy nature of the skin. There's obvious diffuse infiltration of earlobes and forehead. There's a diffuse infiltration, not like the nodular or a plaque-like infiltration that we see in lepromatous pole. Metarosis is present, the loss of eyebrows are there, and it is associated with Lucio leprosy by multiple authors. Some authors regard this as a separate presentation, while some others regard it as a part of Lucio leprosy. The third unusual form is pure neuritic leprosy. Remember, leprosy is a disease manifested by the skin symptoms and by neural symptoms. But what happens when you don't have a skin involvement? What you have is just nerve involvement or neural involvement. So what you see is you see an area of sensory loss along the distribution of an involved nerve trunk. We know that all parts of the skin is infiltrated by branches of cutaneous nerves, isn't it? That is how sensation is carried. Now, what actually happens is leprosy involves one nerve trunk, and the area which is where the sensations are carried by that nerve trunk becomes hypoesthetic. Apart from this decrease in sensation, you don't see much infiltration, you don't see the lesions of leprosy. In fact, when you take a biopsy, you might get a normal biopsy. You have to biopsy the nerve. So in pure neuritic leprosy, you need to biopsy or take a section out of the cutaneous nerve. The motor deficit may or may not be present depending on degree of infiltration and damage. You don't see a skin patch. You don't see an involvement of the skin by your eyes. You need to have a biopsy done, and that too can turn out to be negative. All you have to do is take a biopsy of the involved thickened nerve. The host cell-mediated immunity contains the infection of the nerve trunks, so the infection is limited to the nerve trunks. Two types of pure neuritic leprosy has been described. The first is the primary or the pure neuritic leprosy, in which only the nerve is involved. However, if we take a biopsy, about 1/3 of the cases do show infiltration or infiltration by the M. leprobacilli, but you don't see it clinically, you see it on histopathology. The second form of pure neuritic leprosy is secondary leprosy, in which you have the leprous neuropathy, that is nerve involvement due to leprosy, along with few skin lesions. So that is known as secondary pure neuritic leprosy. Clear? Let's move forward. The fourth variant is the histoid leprosy. It's part of the lepromatous pole, part of multibacillary leprosy, and it's the nodular form. So in histoid leprosy, multiple nodules are formed, multiple papules and plaques are formed, and the background skin is normal. So what you have is smooth, shiny, hemispherical, dome-shaped, non-tender, soft to firm nodules. You have nodules, okay? Roughly about 30. I think about 6 to 50 lesions have been described, but mostly it's around 30 lesions over the body. The nodules can be superficial, subcutaneous, or fixed deeply under skin. But remember, the most important aspect is the background normal looking skin. On biopsy, you see spindle shaped shells which have unusually large number of AFB. Okay? So what actually happens when you take a biopsy from that nodule of histoid Hansen's, you will see spindle cell shaped histiocytes, and inside those histiocytes they are filled with longitudinally arranged long thin AFB. Clear? We have a separate lecture on histoid leprosy. It was discussed last week. So you can go and look at this lecture. It will give you a good understanding of what is histoid Hansen's. It's an entirely different variant, entirely different style of presentation of leprosy. Clear? Let's move forward. The fifth variant is Lazarine leprosy. Okay, Lazarine leprosy is a type of BT leprosy, or it is closer to BT leprosy where it lands on the Ridley-Jopling spectrum. It is characterized by spontaneous ulceration of skin lesions. So, skin lesions spontaneously ulcerate during the course of disease. It is described as an exaggerated hypersensitivity in type 1 reactions. Of course, since it's a part of BT leprosy, you have more chances of type 1 reaction. So it's an exaggerated hypersensitivity or a hypersensitive reaction in type of type 1 reaction. Lazarine leprosy may not have any pre-existing skin lesions or nerve pathology. The patient directly presents with spontaneous ulceration. If the patient presents towards with extensive ulceration and necrosis, few things come into mind. So you have Lazarine leprosy, you have necrotic ENL, and then you have Lucio phenomena. In all this, you can have ulcerations, or you can have non-trophic ulcers of leprosy, which we'll discuss in few slides afterwards. So all of these two are the lepromatous pole, while this is towards the tuberculoid pole, and non-trophic ulcer occurs more in lepromatous pole as compared towards tuberculoid pole. Okay, so these are the differentials of ulcerations in leprosy. If you do a biopsy from the ulcers, you will see necrosis due to extreme cellular hypersensitivity. What do we mean by that? That means there will be extensive lymphocytic and neutrophilic infiltration around the ulcers. The biopsy looks exactly the same as you see in any kind of ulcers, but you do a special stain and you will be able to find AFB. The AFB may be negative because it is BT leprosy, but if you find few AFB positive, even that is enough to make a diagnosis of leprosy in Lazarine presentation. The treatment is to continue MDT and start systemic corticosteroids may be managed as like type 1 reaction. The sixth presentation is inoculation leprosy. That is leprosy which is following any scarification or tattooing, vaccination or needle stick injury and trauma. Now remember, leprosy is like any other mycobacterium. That is what it is, Mycobacterium leprae. So if you have inoculation tuberculosis, you can also have inoculation leprosy. So in inoculation leprosy, the act of tattooing using needles or vaccinations or any needle stick injury or trauma seeds M. leprae at the site of trauma, and you see the clinical presentation of leprosy at that site. That is known as inoculation leprosy. It was described first by Lowe and Chatterjee in 1939. Inoculation of M. leprae in the skin happens, and M. leprae stays dormant for days to years. It can stay there as it is, not much multiplying, for days to years after inoculation. If it gets activated, that is, we know that there is a complicated play between immunity and leprosy. And when that happens, because of the complicated play, the lepra bacilli, when it gets activated and starts multiplying, you see the development of skin lesion around the site of trauma. And most of the time, you see a granuloma there. Clear? Most common site involved are the upper extremities, which are the sites which you usually get tattooed. Okay. And most of the time you see tuberculoid or BT lesions, TT or BT lesions more than lepromatous lesion. You can have lepromatous lesion after inoculation, but most of the time it is towards the tuberculoid pole. Most of the time you see granulomas. Clear? Let's move forward. If we do a biopsy from the granuloma, you see a compact tuberculoid granuloma that is lymphocyte rich with macrophages with large number of epithelioid cells, lymphocytes and several Langerhans giant cells. You see a lot of giant cells there because they are trying to engulf M. leprae and keep it there itself. AFB is difficult to demonstrate because we know towards the tuberculoid pole, AFB is very difficult to demonstrate because they have been destroyed by the immune cells. The differentials include tattoo-sarcoidosis, tattoo-granuloma, inoculation TB, or reaction to red dye of tattoo, or any other inoculation thing like sporotrichosis. A sporotrichotic granuloma can present like that. Treatment is MDT, treated as a case of possibacillary MDT with 3 drugs for 6 months. Clear? Let's move forward. The seventh presentation of leprosy or unusual presentation of leprosy are the non-trophic ulcers. We know that in leprosy we can have trophic ulcers. Okay, so you see it on pressure bearing areas like balls of the joints or fingertips or toe tips. Okay, wherever there is damage, and because of hypoesthesia, the patient doesn't know that the part has been damaged and can lead to ulcerations. But other forms of ulcers, which are the non-trophic or non-neurogenic or non-hypoaesthetic ulcers, which do not happen because of hypoesthesia or anesthesia. So these are the non-trophic ulcers that you can see in leprosy, and very rarely a patient with leprosy can present with just the non-trophic ulcers. Example of how ulcerations can happen in leprosy is spontaneous ulcers that we see in lepromatous leprosy. Spontaneous ulceration in nodules of histoid leprosy have been described. Iris-associated intense type 1 reaction in HIV patients. Ulcers in reaction, for example, necrotic ENL or simple ENL can ulcerate. And Lucio phenomena because of vascular infarction. So these are the reasons. It is not an exhaustive list. You can have one or two more reasons. These are the reasons in which leprosy can present with ulcers. Clear? So these are all non-trophic ulcers. That means they are not because of nerve involvement. They have a separate pathomechanism apart. For example, in Lucio phenomena, you have the necrotic infarct of vessels. In ENL, you have vasculitis. In iris associated, you have increased immune reaction because of reconstitution syndrome. In histoid leprosy, it could be because of decreased nutrition in the center of granuloma. Remember, in histoid leprosy, you see large nodules, and when they become bigger, the center part get necrosed and then ulcerate. And spontaneous ulceration in LL could be because of vascular damage, trauma, and to some extent neuropathic too in some of the cases. Yes. So these are the reasons why you can have non-trophic ulcers in leprosy. Let's move forward. The eighth variant are not the variant of leprosy per se, but variants of the type 2 lepra reaction or ENL. We have discussed individual variants while we were discussing a separate video on erythema leprosum. You go back and search in the playlist of leprosy, leprology, and you will find a separate video on ENL. Clear? Most of the time, the variants of ENL include in necrotic. So majority of them, the patient will present with erythematous new crops of erythematous plaques and papules, clear, and nodules. But if we talk about the variants or the altered presentation of ENL, necrotic becomes the most common variant of ENL. That is why we were discussing necrotic ENL. In fact, in the video on Lucio Leprosy, we have discussed necrotic ENL in some detail. Other variants include pustular or pustular-necrotic in about 0.3%, vesiculobullous or bullous in which you have bulla formation over the ENL lesions, erythema multiforme-like, and sweet syndrome-like ENL in about 10%, 11% of cases. So we need to keep our mind open that even leprosy can present as any symptom or any sign. ENL can also present and have variable presentations in the OPD or in emergency. Let's move forward. The 12th variant is Leprosy Pseudoimbricata. In this case report, it is 35-year-old male with multiple red-colored asymptomatic skin lesions for about 15 months. DDs include tinea, eczema, treated with topical steroids and antifungals, but there was no response. In fact, there was increase in lesions. On cutaneous examination, we saw multiple well-defined erythematous annular non-scaly plaques consisting of concentric rings. So if we know about a disorder known as tinea pseudoimbricata, we see concentric ring-like lesions in scaly plaques in tinea pseudoimbricata. But in this case, leprosy was presenting it as multiple concentric lesions, and that is why the term leprosy pseudoimbricata was used. There was mild lesional hypoesthesia detected, and there was thickening of cutaneous nerve. When they did a slit skin smear, they found BI to be 4 plus and morphological index about 5%. Biopsy showed features of BL leprosy along with AFB positivity, and a diagnosis of Hansen's was made. So with that, we'll finish another lecture on leprosy. In fact, including this lecture, we have covered, if I can count properly, about 21 lectures of leprosy. This is the 21st lecture in leprosy, and this is, I think, 10th or 11th lecture that we have taken back to back. So all of these lectures are present in the leprology playlist. You can go to the channel and click the leprology playlist, go through each one of them. They are important lectures. We have discussed drugs in leprosy, alternative therapies in leprosy, immunology of leprosy, the manipulation of immune system of leprosy, the pathomechanism of nerve damage, biology of M. leprae, xenolation staining, slit skin smear, animal models, vaccines, NLEP, lepra reactions, systemic involvement, eye involvement, Histoid leprosy, Lucio leprosy, all of these have been discussed in extensive detail in each of these lectures. You're free to go and check all of them individually. Any doubts should be mentioned in the comment section. Okay, with that, I would again tell you about the reading recommendation. However, it's not particularly required. If you can go through this lecture once or twice, you will have all sorts of list of different variations of leprosy. Reminding again about this Ruby membership, but do remember that I would like to discontinue Ruby membership in few months. So if you want and if you think that these video lectures are helpful in your residency, consider becoming a Sapphire member of the channel. You will have a join button on the channel page, or the link will be shared through WhatsApp or shared in the description of every video. So do consider becoming a Sapphire member. I have also started a bronze membership, but remember, bronze membership is temporary. It is only till 10th of July. After that, it will be discontinued. This is just so that people can join and have a look at the membership videos and see if they find it to be useful and better. They can become a regular Sapphire member instead. So with that, we'll finish this week's discussion on the rare variants of leprosy. Combine these variants with different forms of leprosy and the spectrum of leprosy. And I hope that with individual lectures, you are developing a proper understanding of leprosy. Leprosy is nothing like BL leprosy, BT leprosy, BT leprosy. It's a spectrum. It has various presentations. It has all these altered forms of presentation. We need to keep that in mind because, after all, we are leprologists. If we will miss leprosy, then God knows what will happen. So make sure that we always have that nudging suspicion of leprosy in the back of our minds. We should train ourselves to recognize leprosy in all its varied forms. Clear? With that being said, this lecture would be the last lecture in leprosy series for the time being. After a few months or multiple months, we'll come back and visit leprosy again, and I'll keep on adding to the leprology videos. But I think we have discussed leprosy for quite some time now and would like to shift gears. As per the poll taken and answered by Sapphire members, we would be starting a discussion on HIV and all the related aspects in the coming few weeks, and we'll discuss that in detail. Till then, do see these videos. We have more than 110 lectures now on the channel, and you're free to see and watch all of these videos. Any comments about any of the lectures, just mention them in the comment section along with the timestamp, and whenever I have time, I'll go through it and answer your queries. Any suggestions regarding future topics or any other aspects of the channel, you can put it there and those will start looked into. And you can email me, but I do prefer that you comment on the channel so that other people with the same doubts can benefit from it. Till then, I'll finish this lecture. We'll return with HIV and other related aspects. Bye bye.